Hello, my name is Stephanie Garberin, and I am an emergency medicine physician at Brown University, as well as a fellow of the Watson Institute Center for Human Rights and Humanitarian Studies. Today, I will be presenting this supplementary module on the management of severe illness and acute respiratory failure in COVID-19. This module aims to provide healthcare providers, including physicians, medical officers, nurse practitioners, and physician assistants who normally work in non-acute care settings and or do not routinely treat patients with severe respiratory infections with the basic skills needed to treat acutely ill patients with suspected or confirmed COVID-19 infection in an inpatient or hospital setting. This module was developed mainly for providers working in lower resource settings. So this may be in low or middle income countries, rural or remote settings, or field hospitals. It was developed in anticipation that providers may be asked to practice beyond their usual scope of practice as part of surge capacity plans to supplement health workforce capacity during the COVID-19 pandemic. The objectives of this module are to understand recommendations and best practices for hospital management of patients with severe and critical illness due to COVID-19 infection, as well as be capable of interpreting common diagnostic tests and carrying out treatment strategies to safely manage hospitalized patients with COVID-19. This module will cover infection prevention and control, as well as the recognition of the patient with severe illness, basics of stabilization and resuscitation, diagnostics, including imaging and laboratory tests, patient monitoring, management, including supplemental oxygen and FiO2, as well as mechanical ventilation, fluid management, and hemodynamic support, medications, and therapeutics. Some further information, including references, are included in the appendix, including basic analysis of blood gas testing. Infection prevention and control measures are extremely important for healthcare providers who are working with patients with potential and confirmed COVID-19. There is a separate Project HOPE module dedicated to this topic. However, I will cover the basic principles of infection prevention and control to keep in mind as a hospital provider. During every patient assessment, it is very important that you know your healthcare facilities protocols for appropriate levels of PPE. In general, for most patient encounters in the hospital, contact and droplet precautions will be sufficient. Usually this includes a gown, a mask or respirator, goggles and face shield, as well as gloves. Airborne precautions are necessary for any aerosol generating procedures. In general, this will require, at the minimum, a respirator and a face shield or eye protection. Whenever possible, it's important to try to use an infection isolation room with special ventilation and air handling capabilities, or negative pressure. However, in many facilities, this is not possible. If this is not possible in your facility, try to place the patient in a private room with the door closed and use an N95 or FFP2 or a higher level respirator, as well as eye and face protection. And as always, hand hygiene is very crucial before and after each patient encounter. The treatments and procedures that require airborne precautions are high flow nasal cannula oxygen, non-invasive positive pressure ventilation, which is BiPAP or CPAP, nebulizer treatments, intubation as well as extubation, suctioning of the respiratory tract, as well as CPR. Next, we will cover the recognition of severe illness. Recognition of patients in need of immediate attention and intervention is your main priority every time you assess a patient. Try to make your best assessment of the severity of the patient's condition. This will help to allow for appropriate allocation of resources, which includes personnel, equipment, medications, oxygen, and a number of other resources. Frequent reassessments are crucial. It's also important to consider that patients who are elderly and or have underlying comorbidities are at increased risk of deterioration and may warrant higher levels of care. The clinical signs and symptoms of COVID-19 are very similar to those that are found in other flu-like illnesses and viral respiratory infections. The majority of patients report fever, cough, fatigue, and some proportion also report shortness of breath or dyspnea. Other symptoms include sore throat, headache, nasal congestion, muscle aches or myalgias. Cough may be dry or productive of sputum. In certain circumstances, may also have hemoptysis. There may also be a loss of sense of taste or smell, or what is known as anosmia. Some patients may also report gastrointestinal symptoms, including diarrhea, vomiting, nausea, prior to developing fever or other typical respiratory symptoms. This is why it's extremely important to have a high index of suspicion when you're evaluating patients for potential COVID-19. COVID-19 has a very broad clinical spectrum of disease. As you can see in this figure, the majority of patients will have mild or uncomplicated illness, over 80%. However, in about 15% of patients, these patients will develop severe disease, meaning that they will require hospitalization or oxygen support. And approximately 5% of patients will require intensive care unit or ICU level of care, including patients who may need mechanical ventilation. In general, case fatality estimates are highly variable. In some countries, case fatality estimates may be as low as 1%. However, in other countries may be as high as 5% or even greater. In general, these differences are due to differences in testing of mild or asymptomatic cases, as well as the resources available to treat patients with critical illness. In general, patients with mild or uncomplicated illness, as well as mild pneumonia, can be managed as outpatients. These patients can be safely managed in their homes within the community and will recover without problems. Patients with severe pneumonia, acute respiratory distress syndrome, sepsis, or septic shock need to be managed in an inpatient or hospital setting. The focus of this module will be on the severe forms of COVID-19 requiring hospitalization. The clinical progression of COVID-19 can be quite variable. However, in general, the time from exposure to symptoms is approximately 5 days. In patients who do go on to develop severe disease, the time to development of symptoms of shortness of breath or dyspnea is approximately 5 to 8 days. And in those who develop ARDS, this occurs around day 8 to 12, with the time to ICU admission being around 10 to 12 days. In general, ARDS can occur fairly quickly within several days after the onset of symptoms of dyspnea. Older patients and those with comorbidities, such as those with cardiovascular disease, including hypertension, congestive heart failure, and coronary artery disease, as well as pulmonary disease, including asthma or COPD, those with diabetes, malignancy, chronic kidney disease, and other reasons for immunosuppression, including HIV, have increased risk of severe disease and mortality. They may present with mild symptoms at first, but they have a high risk of deterioration and in general should be admitted to a hospital setting for close monitoring. So we'll start going through some of the clinical syndromes that you will see in patients with COVID-19 who require hospitalization. The first clinical syndrome is severe pneumonia. So just to review, pneumonia means just inflammation of the lung, affecting primarily the alveoli. Patients with mild pneumonia are those without hypoxia or any respiratory distress, and the majority of those patients can be safely managed at home with self-isolation and symptomatic care. Severe pneumonia is defined as above. There are some differences between the adult and pediatric definitions. In general, for an adult, severe pneumonia is defined as fever or suspected respiratory infection with tachypnea, with a respiratory rate greater than 30 breaths per minute, or with respiratory distress or hypoxia with oxygen saturation less than 93%. For pediatric patients, these patients are defined as having a cough or difficulty breathing and having signs of central cyanosis or oxygen saturation less than 90%, or severe respiratory distress. Alternatively, patients who have signs of pneumonia plus any of these danger signs, which may be inability to breastfeed or drink, being extremely lethargic or unconscious, or having seizures, those are also indications of severe pneumonia and likely need for admission. Acute respiratory distress syndrome is one of the most feared complications of COVID-19. ARDS, or acute respiratory distress syndrome, is by definition a syndrome. So it's defined by a set of clinical signs and symptoms, which can be caused by a variety of etiologies, including infection, sepsis, as well as trauma. The definition of ARDS is based on a number of criteria, including timing, chest imaging, exclusion of a cardiogenic cause of pulmonary edema, and can be graded by the level of oxygenation. The grading uses what's called a P to F ratio, which relies on an arterial blood gas to measure the partial pressure of oxygen, the P, and the F, which is the FiO2, or fraction of inspired oxygen. In more simple terms, I like to describe ARDS as worsening respiratory symptoms with radiographic findings consistent with ARDS and severely impaired oxygenation. It's important to note that ARDS can be seen in both young, healthy individuals as well as elderly with other comorbidities. It's also important to be familiar with ARDS as it can carry a very high mortality rate and may develop in many patients after their initial hospitalization. In many lower resource settings, there may be difficulty in diagnosing ARDS, especially due to a lack of arterial blood gases and availability of chest imaging. So there is a modification to the ARDS definition, which is called the Kigali modification. The timing and origin criteria for this modification are the same as in the Berlin definition. However, the imaging criteria allow for imaging findings on ultrasound to be included, as well as oxygenation using a oxygen saturation instead of arterial blood gas as a measure of oxygenation. And this can be measured with a pulse oximeter. While a bit less common, COVID-19 can also cause sepsis, as well as septic shock in severe cases. Sepsis is essentially concern for an infection causing organ dysfunction. The definitions differ also for adults and pediatric patients. In adults, this is defined as life-threatening organ dysfunction caused by a dysregulated host response to suspected or proven infection. In pediatric patients, the definition in general relies still on the systemic inflammatory response syndrome criteria, one of which must be abnormal temperature or white blood cell count. Sepsis may also progress to septic shock. Shock is a state where tissues and organs in the body are not receiving sufficient oxygen that they need to carry out their functions. So you may be familiar with types of shock such as cardiogenic shock, anaphylactic shock, which happens in allergic reactions, and hypovolemic shock, such as that seen in trauma or hemorrhage. In cases of infection in general, you see a distributive type of shock. Adult and pediatric definitions, again, differ slightly. In adults, septic shock is defined as sepsis with persistent hypotension, and additionally having an elevated serum lactate. In pediatric patients, they have sepsis plus hypotension for their age, as well as any two of the following, including altered mental status, tachycardia or bradycardia, prolonged capillary refill or a weak pulse, tachypnea, mottled skin or petechia or purpura, increased lactate, oliguria, and hyperthermia or hypothermia. Next, we will discuss the basics of stabilization and resuscitation. So when we are assessing acutely ill patients, it's important to understand how to assess and treat conditions which may benefit from emergency intervention. So we always want to use a systematic approach and go back to our basics. So many of you may be familiar with the ABC mnemonic. In the emergency room and in critical care settings, we use this to remember our steps of patient assessment, which we are doing very frequently. So for every patient, your first steps should be to assess these components first. If any of these components are compromised or at risk of clinical deterioration, you must fix it before you move on. So the ABC approach stands for airway, breathing, and circulation. First, we start with airway. The first step is to ensure an open airway. You want to look for obstructions, foreign objects, secretions or vomit, blood, or trauma in the airway. If there is no open airway or there is sign of a threat, you must make interventions to secure the airway. COVID-19 patients may have copious nasal or oral secretions, so try to suction or remove the secretions as much as possible. This algorithm reviews the assessment and treatment pathway for the airway. One of the easiest ways to determine if the airway is patent is simply seeing if the patient can talk. When you first assess the patient, if they can talk, their airway is open. If they can't, look for signs of compromise. Have them open their mouth, look in their oropharynx. If there's lots of secretions or vomit, see if you can suction or remove those. There may be a foreign object. There may be obstruction from the tongue or other soft tissues in the pharynx. If you can easily fix that obstruction, you should do so, and then see if you now can have the patient talk and if their airway is open. If not, you must make plans to secure the airway. There are a number of ways to secure the airway. In simple circumstances, the first step may be to simply do a head tilt or chin lift maneuver to open the airway. So the first step to try is to perform a head tilt or chin lift maneuver to open the airway. To do this, you simply place one hand on the forehead to tilt the head gently back and lift the chin to try to create a direct channel of air to the lower respiratory tract. Additionally, a jaw thrust maneuver can help move the tongue out of the way to remove obstructions. To do this, simply place your fingers on either side of the lower jaw on both sides and rest your thumb on the patient's cheek and gently but firmly pull the lower jaw forward and up. Airway adjuncts, such as these seen on the right, include oral airways as well as nasopharyngeal airways. And these are simple tools that can help you get past an obstruction. A nasopharyngeal airway, which is also known as a nasal trumpet, is a flexible tube that you can insert into the patient's nose, and it goes all the way back into the hypopharynx and can help relieve obstruction from the tongue, which may be lying on the posterior pharyngeal wall. An oral airway works in a very similar fashion. It's inserted through the mouth and rests and is seated at the back of the hypopharynx to relieve obstruction. Keep in mind, both of these you must use extreme caution in any patients with facial trauma, especially the nasal airway. In general, intubation should only be performed by an experienced provider. And in many lower resource healthcare facilities, intubation may not be an option at your healthcare facility. And this may be due to a lack of material resources such as ventilators or medications needed for intubation, as well as lack of provider experience or availability. The next step in the ABCs is B for breathing. This step is extremely important in patients with severe COVID-19 who may have severe breathing problems, including respiratory distress and respiratory failure. So when you're assessing breathing, you want to see if there are signs of respiratory distress or failure. To do that, there are several components to look at. First, you want to see if there are signs of rapid breathing or tachypnea. In adults, this is generally defined as a respiratory rate over 20 breaths per minute. This is usually pretty obvious in a person who has respiratory distress. However, if you're unsure, make sure you're counting carefully over 30 seconds to 1 minute to assess respiratory rate, because it can be difficult to measure an accurate respiratory rate if you're measuring for a shorter period of time. Next, you also want to look for signs of increased work of breathing. So usually you can ask a patient to simply start talking and see if they can complete full sentences. If they have to stop to catch their breath or gasp for air, or if you see them walking and they need to stop frequently to catch their breath, this is a sign of increased work of breathing. Other signs are the use of accessory muscles. These are accessory muscles of respiration, as well as retractions. Other signs include nasal flaring or seeing that the patient is seated in a tripod position where they're seated upright and they're kind of leaning over their knees or putting their hands on their knees to help them breathe. Next, you want to measure oxygen saturation. So this is best done with a pulse oximeter to assess for hypoxia or an oxygen saturation less than 92%. You can also look for signs of cyanosis. In general, this will look like bluish or purplish colors of the lip or face. So in this video, we see a patient with increased work of breathing and respiratory distress. So what we want to focus on is the neck, which is where we look for accessory muscle use. So here we can see that this patient has use of their sternocleidomastoid muscles, their scalene, even their upper neck and back muscles, the trapezius muscles, to help them breathe. You can also see that they have retractions or a sucking in of muscles of their neck. You want to look at several locations for retractions, including supraclavicular area, intercostal, suprasternal, substernal, as well as subcostal areas. This video shows a patient also with severe respiratory distress and respiratory failure who is both tachypnic. You can also see large movements of the abdominal muscles that the patient is using to try to help breathe. You can also see a sucking in or intercostal retractions. This looks kind of like the space in between the rib is being sucked in, and it's a sign of severe respiratory distress. So this may be a review for many people, but the pulse oximeter is one of the most valuable tools you'll have in addition to your own clinical assessment for management of patients with COVID-19, especially in low resource settings. So it's important to be comfortable with using a pulse oximeter and understanding its limitations. So the way the pulse oximeter works is it uses an infrared light as well as photodetectors to detect how much oxygen is in the blood based on the way the infrared light passes through the finger. So to use the probe correctly, make sure that you're inserting the finger directly into the probe so that the red light or the infrared light is centered directly over the fingertip. You need to make sure the probe is not too tight, which can cause constriction of the circulation, and also make sure it's not too loose, in which case it may fall off, also causing inaccurate readings. There are a number of reasons why you may have inaccurate pulse oximeter readings. People with nail polish, this can interfere with the infrared light, so try to remove nail polish. Patients who are moving or shivering, this may dislodge the probe and cause inaccurate readings. Patients with shock or hypothermia may have decreased blood perfusion to their extremities and also cause inaccurate readings. Additionally, an important consideration is that constriction of the extremity that's proximal to the finger with the probe, for instance, from an inflated blood pressure cuff or a tourniquet, which may be used to get blood tests, will cause decreased blood flow to the finger and therefore cause decreased oxygen saturation and may cause an inaccurate reading. This is the algorithm for assessment of breathing. So if your oxygen saturation is greater than 92%, you can continue to reassess this patient carefully. If it's less than 92%, some interventions you can try are: one, if the patient isn't already sitting upright, you can try to have them sit upright. This in general helps with ventilation and also is more comfortable for the patient and also avoids aspiration. Immediately place them on supplemental oxygen, and this can be with a number of different devices, which we will cover later in this module. It might be a nasal cannula, a face mask, or a reservoir bag. You want to closely reassess them after you start them on the supplemental oxygen and recheck their pulse oximetry or their oxygen saturation. If it's greater than 92%, the patient's doing better and you continue to reassess them. If it still is not greater than 92%, you should start considering other methods of delivering oxygen, including high flow oxygen, non-invasive ventilation, or intubation and invasive mechanical ventilation. If patients also have some underlying respiratory illnesses such as asthma or COPD, you may also want to consider using medications such as salbutamol or albuterol. If they have history and signs of congestive heart failure, you may also want to consider diuretics or potentially nitroglycerin. The next step in the ABCs is C for circulation. So this is where you assess cardiovascular perfusion. This is especially important in patients who may develop sepsis and septic shock. First, you want to check the blood pressure and see if the patient is hypotensive. Also, see if there are signs of poor perfusion. Are the extremities cold or clammy, or are they covered in sweat? You want to see if there are any signs of cardiac failure. For instance, are the legs swollen? Are there distended neck veins? This algorithm goes through the assessment and treatment of circulation. So if a patient is hypotensive, in patients with COVID-19, in general, we recommend using a conservative fluid strategy. So rather than using large fluid boluses, for instance, 1 to 2 liters for adult patients or 30 milliliters per kilogram, you want to use much smaller boluses and have frequent reassessments. In general, we recommend 250 to 500 milliliter IV fluid boluses at a time with frequent reassessment at least every 15 to 30 minutes. If patients have signs of improvement in their mean arterial pressure without any signs of volume overload, you can continue with fluid resuscitation. However, if there are no signs of improvement and there are also any signs of volume overload, stop fluid boluses and start vasopressors as soon as possible. In this next section, we'll cover some of the common diagnostics that you may use in a hospital setting for COVID-19. First, we'll cover imaging. In general, chest radiograph as well as lung point-of-care ultrasound are the primary lung imaging modalities for COVID-19 in most low-resource settings. Lung ultrasound should only be performed by experienced clinicians and will not be covered in detail here. In general, there's a minimal role for CT or computed tomography for the diagnosis or management of COVID-19. Although in some circumstances, if it is available, it may be useful to exclude other causes of respiratory failure. There are many different approaches to reading a chest radiograph. What's most important is that you are consistent and use a systematic approach every time you evaluate a chest radiograph so that you don't overlook important findings. A common approach is the ABCD mnemonic. Yes, it's another alphabet, but it's fairly similar to the one that's used for the assessment of patients with a few additions. First, A is airway. You want to look at the tracheobronchial tree. So you want to start with the trachea. Is it midline? Does it look like it have any strictures? For patients who may have an endotracheal tube, you want to see if the tube is in the correct position and look at the carina, which is where the right and left main stem bronchi take off. In patients with COVID-19 suspected or confirmed infection, you'll be especially interested in looking at the lung field. So B, which is for breathing. You want to look at the lung and the pleura, looking for pulmonary infiltrates, pleural effusions. You also want to evaluate if there's any sign of pneumothorax or pulmonary edema. C stands for circulation. You want to look at the heart borders, cardiac position and size, as well as the mediastinum, any pericardial abnormalities, as well as the pulmonary vasculature. D stands for disability. So this mainly means bony structures. You want to look at all the bony structures, including the ribs individually, as well as the humerus and vertebra as well, to look for abnormalities. E stands for everything else, assessing for any potential foreign bodies for patients who may have tubes, lines, or drains, such as endotracheal tubes, central venous catheters, or chest tubes. You want to assess if those are in the correct position. You also will want to assess if there are any other devices, including pacemakers, and also evaluate for the GI tract and the gastric bubble, especially for patients who may have a nasogastric tube, especially those, or an orogastric tube, especially those who are intubated, to assess if those are in the correct position. This image reviews the structures that can be seen on a normal chest X-ray, and we'll go over normal and abnormal chest X-rays. So this will usually take a bit of practice. It's very important to become familiar with what the normal chest X-ray looks like so that you are more familiar with identifying the abnormal ones. The chest radiograph findings in COVID-19 can be fairly nonspecific. Airspace opacities are usually seen. They are generally bilateral, although can be unilateral. They can look like consolidations or patchy ground glass opacities. They tend to be more peripheral and in the basilar, the lower segments of the lung. The more lung segments that are involved generally indicates more severe disease. Pleural effusions in general are fairly rare, and it's important to note that the infiltrates may initially be very subtle, and chest radiograph often can look normal in the earlier course of the disease, even in patients who do develop severe complications. So here we see both a normal chest X-ray for comparison, as well as an abnormal one in a patient with COVID-19. In this image on the right, you can see that this patient has bilateral opacities on both sides. They're kind of patchy looking, especially in the left lung fields. You can see what looks like consolidation as well. And again, another patient with COVID-19. This one is a bit more subtle. However, again, if you compare this to the normal chest x-ray, it becomes more obvious that there is something abnormal. Here you can see these a bit more faint but bilateral ill-defined opacities, somewhat diffusely spread out in all of the lung zones. This is a patient with more severe disease with diffuse bilateral opacities. You can see on both sides this haziness and patchiness, which is consistent with ARDS. And another patient with severe ARDS with extensive bilateral alveolar consolidation and opacities. In addition, you can see this line here, which is the endotracheal tube, and another line here, which is where the central venous catheter is in place. In general, ARDS can look fairly nonspecific on a chest x-ray. So it's always important with any radiographic images to always take into consider the clinical presentation. For patients who may have signs of what look like pulmonary edema or bilateral interstitial infiltrates, you need to consider whether clinically they have any signs of heart failure. If they don't have any signs of heart failure or volume overload, you must consider ARDS. The time course of ARDS also may help in differentiating it from other pulmonary edema, such as from congestive cardiac failure. And in general, while CT scans are rarely available in lower resource settings and generally do not change management very much, these images illustrate a patient with both chest x-ray as well as a CT scan. On the chest x-ray, you can see extensive bilateral opacities consistent with severe COVID-19 and ARDS. On the CT scan, you can see bilateral large areas of ground glass opacities with which is more prevalent at the bases with areas of consolidation as well. Next, we'll discuss common laboratory tests that are ordered in patients with COVID-19. In general, the laboratory tests that you may have available at your facility may be different than what's recommended here. So in general, order only what you think may change management. In general, we try to order a complete blood cell count. A white blood cell count tends to be lower, normal, or with lymphopenia or normal. However, there can be elevations as well. In general, mild thrombocytopenia is not uncommon. Severe thrombocytopenia, however, or platelets less than 100 is associated with poor prognosis. Basic metabolic panel, as well as electrolytes and magnesium are helpful to determine if there are electrolyte disturbances which may need correction. And importantly, also will evaluate for any signs of kidney dysfunction and injury. Coagulation studies, if they are available, can be helpful to assess for COVID-related coagulopathy, which is a form of disseminated intravascular coagulation. Pregnancy test in general should be recommended for any woman of childbearing age. Hepatic function tests are often abnormal with some mild elevations in transaminase levels, ALT and AST. However, severe elevations of the transaminases and fulminant hepatitis are extremely rare. Troponin or cardiac enzymes may be used to assess for the presence of myocarditis. D-dimer level is often elevated, and studies have shown that a severe elevation in D-dimer may be associated with poor prognosis. There are a wide array of other tests that can be ordered, including C-reactive protein, lactate dehydrogenase, et cetera. And these often will be abnormal. However, in general, often do not change management significantly, in which case we do not recommend them. Additionally, it's important to remember that these patients may be severely ill and may also have other sources of infection. Blood cultures, as well as other viral tests, may be used to assess for co-infections or alternate sources of infections. These should be done according to your local guidelines and availability. Studies have also shown, and we have seen, that having another respiratory virus or a co-infection, such as with influenza or rhinovirus, does not exclude COVID-19. So in general, doing both testing for COVID-19 as well as for other respiratory viruses may still be indicated. Next, we will discuss patient monitoring. Regular, frequent patient monitoring is both crucial for early recognition of deterioration, as well as to monitor your response to treatment to determine if what you're doing is working or helping the patient or not. You want to know which clinical parameters to monitor, as well as how often, and this will vary based on the patient's presentation, as well as the level of care where they are admitted. And you want to be able to respond to abnormal and changing clinical parameters. So in general, if your healthcare facility has a early warning score system or a system for patient monitoring, you should follow protocols. In general, using a standardized early warning score is helpful to be able to consistently assess patients for signs of deterioration. In general medical wards, we recommend that at least every 4 hours, patients should have assessment with vital signs as well as a clinical assessment. And for patients in the intensive care unit, they should be assessed at least every hour, if not more frequently. Patients with COVID-19 can acutely decompensate several days after their admission or the onset of symptoms of dyspnea. So it's important to be closely monitoring them for any signs of decompensation. Patients who are elderly and have underlying comorbidities have much higher potential for deterioration. So in certain circumstances, you may want to have those patients go to the ICU, even if they do not have severe or critical signs of illness at the beginning. Similar to your initial ABC assessment, during every monitoring assessment, you want to assess your ABCs. In particular, you want to look at whether there's an increasing oxygen requirement, especially how quickly that oxygen, their requirement for oxygen is increasing. For instance, if a patient is going from needing a oxygen of 2 liters per minute to 6 liters over a course of several hours, this should make you very concerned that this patient is deteriorating. And a rapidly increasing oxygen requirement is a sign that this patient may require mechanical ventilation. You also want to assess for other danger signs in work of breathing, as well as increases in respiratory rate. You also want to assess for any changes in mental status, especially drowsiness, as well as agitation and confusion. These may be signs of respiratory or hemodynamic compromise, and you should evaluate the patient to see if they may be deteriorating. In addition, hemodynamic instability, including tachycardia, as well as hypotension, which may be signs of shock. Next, we will cover general management strategies. So there are currently no definitive vaccines or therapies for COVID-19, although You've probably heard that there are many studies and many trials ongoing. The strategy in general, however, is to focus on providing high quality supportive care. First, you want to assess severity of patient's illness, and for those who have severe illness, providing high quality supportive care can be life-saving. Many recommendations are changing on a daily basis, so trying to stay up to date is a good idea. There are a lot of different sources that you can go to. I've listed a small selection of some guidelines that are helpful here, as well as in the appendix. Next, we will cover the different modes of supplemental oxygen. In general, the goal oxygen saturation for COVID-19 patients is to target an oxygen saturation between about 92 to 96%. It's important to note that targeting a higher oxygen saturation like 99 or 100% is not necessarily necessary and can actually be harmful. Also, this may diminish your hospital supply, especially if you are relying on oxygen canisters. The FiO2 is the fraction of inspired oxygen. This is basically the concentration of inhaled oxygen. To review, room air, which is what you're breathing right now, has an FiO2 of 21%. There are multiple methods of delivering oxygen, and these will vary based on the FiO2 delivered, as well as the oxygen source required for that delivery. Many facilities may only have a limited selection of oxygen delivery devices, so it's important to know what options your healthcare facility has and what the maximum level of oxygen or respiratory support available is, as well as any nearby centers that you can consider transferring patients to for higher levels of respiratory support. Now we will review the most common type of supplemental oxygen delivery device. So this is the nasal cannula. This is a lower flow supplemental oxygen device. It delivers 1 to 6 liters per minute of oxygen, or a 25 to 45% FiO2. In general, it's very well tolerated for patients, including pediatric patients. You can eat, drink, and talk with it on. You can use it with both an oxygen concentrator, which may be more common in lower resource settings, as well as with an oxygen cylinder or tank, or with, if your healthcare facility has wall source of oxygen, can be used with that as well. When you're using the cannula, make sure that the 2 nasal prongs are securely inserted into the patient's nares, and secure the tubing behind the ears and under the chin to make sure it stays in place. As patients with COVID may have a lot of secretions, make sure to have them try to remove secretions and blow their nose prior to placement, as it will not deliver much oxygen if they have a lot of secretions in their nose. Next is the simple face mask. So this delivers a higher flow of oxygen, 6 to 10 liters per minute, than the nasal cannula, and it delivers about 35 to 60% FiO2. It also provides a bit of humidification as well. It cannot be used with an oxygen concentrator, however, so you do need an oxygen cylinder or a wall source of oxygen. A non-rebreather mask, also known as a mask with a reservoir bag, can deliver up to 90 or 100% FiO2 with a good seal, meaning that it's securely fitted and tight against the face. In general, these are used for short-term or temporary or bridge use. When you use this, you want to make sure that the reservoir bag, as seen here, is fully inflated. Usually you'll want to just set the flow rate to 15 liters per minute. And you want to make sure that when the patient inhales, the reservoir bag deflates by about 1/3. In any delivery device where you're delivering a high FiO2, such as a non-rebreather mask, you want to use a lot of caution, especially in patients with chronic respiratory illness such as COPD, as you may cause CO2 or carbon dioxide narcosis. This happens when you give too much oxygen and it decreases the patient's respiratory drive. And you'll notice this if you see that your patient is becoming very drowsy or maybe confused. And this is very dangerous as it can eventually lead to respiratory collapse. So in patients who have chronic underlying lung issues like COPD, you want to actually have a lower target oxygen saturation, as low as 90 or even the high 80s, up to 92 or 93%. High flow nasal cannula is similar to a regular nasal cannula, but uses specialized equipment. This may not be available in many lower resource settings. However, it can deliver a much higher flow rate, up to 60 liters per minute, and a much higher FiO2, which is titratable from 30 to 100% FiO2. It uses a warmed, humidified circuit, and also uses a special nasal prong, which actually occludes the nostrils so that it actually creates a bit of positive end expiratory pressure, or PEEP, as well, which can be beneficial. And we will discuss PEEP in further detail in the next section. Next, we will cover mechanical ventilation. So in general, mechanical ventilation allows you to control oxygenation as well as ventilation, or CO2. What are the parameters that determine oxygenation? So this is the fraction of inspired oxygen, or FiO2, as well as the PEEP, which we'll discuss next. The components that determine the CO2 is the minute ventilation, which is defined as the tidal volume multiplied by the respiratory rate. This means that if you either increase the tidal volume or the respiratory rate, you'll increase the minute ventilation. And this is what you do when you're trying to, quote, blow off CO2. I'll now briefly go over the concept of PEEP, as well as its importance in ARDS, which is relevant to patients with COVID-19, as patients with severe disease have a high likelihood of developing ARDS. So what is PEEP? PEEP is positive end expiratory pressure, which basically just means the maintenance of positive pressure within the lungs, or the alveoli, at the end of expiration. So PEEP helps keep the lung alveoli open. If you can see in this diagram on the left, you can see the alveoli and the capillary membrane or interface. You can see in the normal lung, the alveoli and the capillary are very close together, allowing gas exchange. However, on the right, in a patient with ARDS, you can see there is some separation due to inflammation, as well as fluid in this space, which is preventing efficient gas exchange. By keeping the alveoli open, you're allowing for more efficient gas exchange or diffusion at that membrane. A helpful way to think of PEEP is to think of a balloon. So when the balloon is deflated, you know that it takes a bit more effort to start blowing the balloon up. However, after you start blowing the balloon up, you'll notice that it's a lot easier to inflate and easier to expand. So PEEP basically keeps the balloon a bit inflated or expanded so it doesn't fully collapse, and it expands more easily, allowing more efficient oxygen exchange. It also prevents complete collapse, which would require more pressure to reopen it. And also this repeated opening and closing can also cause what's known as atelectatic trauma, or injury from a repeated opening and closing of the alveoli. In ARDS, the lungs tend to become stiff or less compliant, meaning it's harder to expand them or inflate the lungs. However, what people have noticed in patients with ARDS from COVID-19 is the stiffness or the compliance in the lung is less severe than is seen in ARDS from other conditions, and that the ARDS is highly responsive to PEEP. In general, this is the reason why a high PEEP strategy is recommended for patients with COVID-19. So now we'll briefly cover the use of non-invasive positive pressure ventilation. Non-invasive positive pressure ventilation provides a baseline level of positive pressure, or PEEP, to keep the alveoli open, which we saw was very important in patients with ARDS and COVID-19. There are generally two forms of non-invasive ventilation modes, including BiPAP and CPAP. BiPAP, or bilevel positive airway pressure, provides an increase or differential pressure when the patient triggers a breath or inhales. Whereas in CPAP, airflow is adjusted to maintain a continuous pressure during both inspiration and expiration. In general, both methods help to recruit alveoli, or basically inflate them and reduce atelectasis. It prevents the alveolar collapse during inspiration, as well as decreases the work of breathing. It can be very helpful to use non-invasive modes of ventilation in patients with congestive heart failure or COPD, and can be used to avoid intubation, especially in patients who do not wish to be intubated, or in facilities where there are not providers or resources available for intubation and invasive mechanical ventilation. It's important to have a high degree of caution with this. However, as it's been shown that non-invasive ventilation can spread COVID viral particles. As you can see, the mask, while it is closely fitted using a soft interface around this mask, as well as snug straps, the pressure from the air that's pushed into the mask can leak around this mask, and therefore increase the risk that viral particles will be sprayed around the edges of the mask if it is not very tightly fitted. So we will briefly review how to use non-invasive positive pressure ventilation in a patient. So first, you need to make sure that your patient is sitting upright. You should not be doing this in any patient who is lying flat or supine. In general, try to have them sit fairly upright between 30 to 90 degrees. You want to apply the mask snugly and make sure it is fitted tightly to their face, although not too tightly, and secured to the face with the straps. On your ventilator, you'll have several settings that you can adjust. In general, this is the inspiratory airway pressure as well as the expiratory airway pressure. You can start with an inspiratory pressure about 8 to 10 centimeters and an expiratory pressure about 4 to 5 centimeters. You can then adjust this going up slowly by 1 or 2 centimeters every 5 to 10 minutes to reach a goal of about 10 to 16 centimeters of IPAP and 8 to 10 centimeters of EPAP. Usually you will start with a FiO2 of about 100%, and then you want to try to lower this as quickly as possible to maintain an oxygen saturation over 92%. Patients in these modes can determine their own respiratory rate, the length of their breath, as well as the flow rate. Many patients, especially those with ARDS due to COVID-19, will warrant intubation and invasive mechanical ventilation. In general, you need to have a low threshold for early intubation of patients. Signs that a patient that needs to be intubated is a rapid progression or rapid deterioration over hours. For instance, significant increase in work of breathing, significant increase in oxygen requirements. Additionally, signs of severe hemodynamic instability or multi-organ failure may also be indications for intubation as well. We will not cover the intubation procedure here. This should only be performed by an experienced provider. In general, the most experienced provider available should be the one performing the intubation to ensure the highest chance of success and reduce the chance of transmission to other healthcare providers or patients. As always, with any intubation procedure, you must use airborne precautions, including a respirator, gown, face shield, or goggles, and ideally use of an isolation room or a negative pressure room. So the ventilator can cause quite a bit of anxiety for providers who are not accustomed to using these. So first, it's important to, if you do have a ventilator available at your facility, to understand what machines you have and how to use them. However, I'll go over some general concepts and review the general principles of use for a mechanical ventilator. There are multiple modes of ventilation possible, and this refers to the method of inspiratory support delivered. Follow your own local protocols if you have them regarding ventilation strategies. Here, I will discuss just one concept of volume assist control, which is generally recommended for patients in the initial stages of after intubation, and can also be used in patients with ARDS and with COVID-19 respiratory failure. Ventilator modes in general fall into two categories: volume control or pressure control. Additionally, we will discuss the use of a lung protective strategy for ventilation, which in general should be used for all patients with ARDS, but can be used in any patient with COVID-19 as well. So what does lung protective strategy mean? You may hear people talking about this or using the term low tidal volume ventilation, or even ARDS-net or ARDS network strategy. So this basically is referring to a strategy in which you use lower than traditional tidal volumes, so between 4 to 8 milliliters per kilogram tidal volume, and appropriate levels of PEEP. This has been shown in studies to improve outcomes in patients with ARDS as compared to traditional approaches to ventilation, which use much higher lung tidal volumes, which were shown to be associated with ventilator-associated lung injury. The ARDS-net trial, which was conducted in the year 2000, showed a decreased mortality using this strategy, and it is therefore recommended and is used in intensive care units around the world for patients with ARDS, and is recommended for patients with COVID-19. Here we'll go over the settings of a mechanical ventilator and the screen. So the ventilator can be very intimidating. So one, familiarize yourself with the ventilator you have. They're all a bit different. Here's just one example, but the principles are all fairly similar between different machines and models. So in general, what you as a provider are interested in is the components that you can control. So here we'll go over what you can set on the ventilator, and then strategies for ventilator management in patients with ARDS and COVID that require invasive ventilation. So at the bottom here, you can see there are settings for mode. This will look different on different ventilators. In general, AC or VC or ABC all mean the same thing, which is a volume control, assist control mode. Other things that you can set are the respiratory rate, the tidal volume, the fraction of inspired oxygen, as well as the PEEP. So in assist control, this is commonly used as the initial mechanical ventilation setting, for instance, after an intubation. Here, you must set the FiO2, tidal volume, rate, and PEEP. In general, for patients with COVID and ARDS, you should start with an initial tidal volume of about 6 milliliters per kilogram. You can either use this ideal body weight calculation, which is shown here, or a tidal volume table, which is basically based on the patient's gender and height. And you can find that in the appendix. You should set the initial respiratory rate anywhere from between 12 to 20. So you can set the initial tidal volume at 6 milliliters per kilogram. And you can also use an ideal body weight calculation, which is shown here, or in the tidal volume table, which is in the appendix. In general, you can set the respiratory rate about 16 to 24 breaths per minute. This may need to be adjusted, however. And for PEEP, you can use the ARDSNet PEEP table, which is shown on the next slide, which is adjusted based on the FiO2. Lastly, you want to adjust the initial FiO2. So in general, after intubation, you'll start at 100%. However, you want to rapidly wean that down or decrease it to the lowest amount that's needed to maintain the patient's oxygen saturation above 92% and below 96 approximately. And this is just the reference table showing the amount of PEEP to use for different levels of FiO2. You will often need to titrate your initial ventilator settings, and this should be based on a blood gas. So your pH goal is normally between 7.25 and 7.45. If you find that your pH is alkalotic or over 7.45, you should decrease the respiratory rate. If the pH is between 7.15 and 7.25, then you can try to increase the respiratory rate until the pH is greater than 7.25 or the PaCO2 is less than 25. If the pH is less than 7.15, then you should try to increase the respiratory rate to a maximum of about 35 breaths per minute. However, you should also try to consult a specialist for further assistance. If needed to achieve low tidal volumes, you can consider tolerating hypercapnia and acidemia with a pH of greater than about 7.2. Additionally, because tidal volumes are low, the respiratory rate often has to be fairly high to accommodate this, with respiratory rates from 20 to as high as 35 breaths per minute. This means that you will need to have good sedation of the patient to be able to achieve this. Prone positioning is highly recommended in patients with severe ARDS or even those with moderate ARDS. So proning essentially means turning the patient into the prone position. This, in general with ARDS, historically has been only referred to for patients who are intubated and invasively mechanically ventilated. The way this is thought to benefit patients is that by having the patient lie prone, you're increasing recruitment of alveoli in those posterior lung regions, which can become atelectatic if a patient is, for instance, lying on their back or supine for the entire day. Increases ventilation and perfusion matching. And it can also help with secretion clearance and avoiding aspiration and secretions from going back into the respiratory tract, which is common when they're lying supine. Some drawbacks are that it can require significant healthcare resources, especially in an intubated patient. Quite a few healthcare providers, at least 3 to 4, are needed to carefully turn the patient and ensure that they are not dislodging the endotracheal tube, the many lines that the patient is probably attached to, and also ensuring that the healthcare personnel have enough PPE in order to do this. So this can be difficult. However, there is increasing evidence during this COVID-19 pandemic that there may be a benefit for even patients who are not invasively ventilated for what's called awake proning. So you can see in this lower picture, patients can themselves turn into a prone position and stay that way for as long as they can manage at least 30 minutes, but could be even longer for several hours. Several centers have used a protocol of doing awake proning for 2 to 4 hours per day and doing that several times a day. There are some additional references for techniques for proning as well that are in the electronic PowerPoint presentation. In general, extubation can take quite a while in patients who have been intubated for COVID-19, as much as 1 to 2 weeks or longer of being ventilated mechanically. However, you do want to try to extubate patients in a safe manner. So in general, extubation should be considered only when you're quite confident that this person can be extubated to a nasal cannula. And the readiness for extubation should follow your standard practices, including spontaneous breathing trials and having weaned the patient down appropriately. It's important to be very cautious that these patients can decompensate after extubation and may need reintubation. And in patients who have a failure to extubate over 2 weeks, it's important to also consider whether they may need a tracheostomy. Here, I also have included some respiratory support algorithms that may help you with making decisions about increasing or de-escalating levels of respiratory support. In general, ECMO, which is the very last stage, is reserved for severe cases of respiratory failure and ARDS that are not responding to treatment in patients who have a reasonable chance of recovery. However, the exact indications are still unclear, and this is a resource that is extremely limited in the majority of lower resource settings, and even within high resource areas, it can be difficult to have patients get ECMO. And here's another respiratory support algorithm also going through indications for endotracheal intubation. If you are in a healthcare facility where a ventilator is unavailable, use the highest level of respiratory support available. So this can be a regular nasal cannula. You can also, if you have a oxygen cylinder or a wall source of oxygen, even use essentially high flow nasal cannula using a regular nasal cannula, going up to 10 or even higher liters per minute on a regular nasal cannula. You can also try to use oxygen mask with reservoir bag for longer periods of time, as well as do trials of awake proning. If you're in a location where ventilation is not possible, it's also important to consider what resources you have for transfer in the local area or in the region to determine if the patient may need transfer to a higher level of care where they may have access to other modalities, including invasive or non-invasive ventilation. Next, we will cover principles of fluid management and hemodynamic support. So the general principles for fluid management are to use a conservative fluid resuscitation strategy, meaning avoiding large fluid boluses. If adult patients have signs of shock, you want to start with small boluses of 250 to 500 milliliters of crystalloid fluid at a time, and frequently assess them for improvements in their blood pressure and also for any signs of volume overload, in which case you should stop fluids immediately. In children, you also want to use lower volume crystalloid fluid boluses with 10 to 20 milliliters per kilogram of crystalloid in the first 30 to 60 minutes. Your overall goal is to aim for an even or negative fluid balance. And crystalloid fluids, which in general will be normal saline or lactated ringers, are the preferred fluids for resuscitation. So some considerations in children. So especially children with severe acute malnutrition should use an even more conservative fluid resuscitation strategy. Um, there is not a lot of evidence about the management of children with severe malnutrition with COVID-19. So these recommendations are generally drawn from prior studies in critically ill children in resource limited settings. You may be able to use more aggressive fluids if you're in a setting with availability of intensive care, including having mechanical ventilation resources. However, this should be done on a case-by-case basis with preferably with a specialty pediatric consultation. Important to regarding hemodynamic support in patients who have persistent shock or hypotension with a MAP of less than 65, despite fluid resuscitation, begin vasopressors early. The first line treatment is noradrenaline or norepinephrine. However, you can also use adrenaline or epinephrine or vasopressin. Peripheral vasopressor use is generally acceptable and considered safe for short-term use, especially when central venous access is unavailable. If you're using peripheral vasopressors, which is essentially just vasopressor use through a standard peripheral IV, make sure to watch for any signs of extravasation or leakage of the medication around the vein, as well as any signs of local tissue necrosis, in which you should stop vasopressors immediately. Vasopressors can also be delivered through an intraosseous needle. Next, we'll cover medications. In patients who require hospitalization, we recommend early empiric antibiotic therapy, which would cover for severe pneumonia as well as respiratory failure. In many settings, this will generally be ceftriaxone and azithromycin or doxycycline. However, this may depend on your local protocols as well as availability. Patients with COVID-19 often have fevers, which can be quite high. Acetaminophen or paracetamol is generally recommended over NSAIDs. There have been concerns about NSAID use in COVID-19 based on some reports that patients had worsening clinical condition with NSAID use. However, there's overall very poor and insufficient evidence that there are actually any negative outcomes, and more research needs to be done on this issue. In areas where there is significant community transmission of influenza, it is reasonable to start a patient on a neuraminidase inhibitor, such as oseltamivir, to improve any symptoms of potentially concurrent influenza. There is no evidence to support the use of corticosteroids unless this is indicated for another reason, for instance, in a patient with COPD or asthma exacerbation. Patients who have underlying bronchospasm or bronchoconstriction, for instance, in asthma or COPD, may benefit from salbutamol or albuterol or ipratropium or other inhaled medications. However, it's very important to avoid nebulized medications as this increases aerosolized viral particles. Additionally, equivalent doses of medication can be given through the use of a metered dose inhaler, ideally with a spacer to allow for effective drug delivery. And in general, one nebulizer vial, a standard vial of albuterol, is approximately equal to 4 to 8 puffs of an inhaler. In settings where you may not have a commercially available spacer, it is easy to make your own spacer with a plastic bottle. For instance, as you can see here, using just a 500 milliliter plastic bottle with a small hole cut out for the inhaler can be equally effective. And further instructions for this are also included in the appendix. Other therapeutics which are useful for all critically ill patients include the use of medications to prevent venous thromboembolism. In general, low molecular weight heparin can be used subcutaneously to prevent venous thromboembolic complications in both adolescents and adults who do not have any contraindications for anticoagulation. Additionally, gastrointestinal prophylaxis to prevent stress ulcers and GI bleeding is recommended. This can be a histamine 2 blocker or a proton pump inhibitor. In general, should be considered in any patients who have prolonged mechanical ventilation, any coagulopathies, or any signs of multiple organ failure or other multiple underlying comorbidities. There are a number of other medications and therapeutics which are undergoing studies and trials to evaluate for safety and efficacy. This area is rapidly evolving and therefore will not be discussed in depth in this module. However, it is covered in the diagnosis and management module in more detail. However, some potential therapies which may have benefit, however, have insufficient evidence include chloroquine or hydroxychloroquine, remdesivir, convalescent plasma, as well as anti-interleukin 6 agents. Concludes this portion of the module. You will find, as mentioned before, references including definitions as well as a brief primer on blood gas analysis in the appendix. Thank you very much for your attention, and thank you very much for your care of patients with COVID-19 around the world.